All right. Hey, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller. And today we have a very special guest, Dr. Philip Ovadia.
Thank you, Kerry. It's great to be here with you. It was really good to connect with you. A few months ago now, we were at a conference together. And of course, we are local to each other.
Yes, I know. I thought that was super exciting. We were at that Metabolic Health Conference in Clearwater, and you're in St. Pete, is that right?
Yes.
Yes.
Yeah.
Okay. Which hospital do you operate out of?
Well, so I actually don't operate out of St. Pete or out of Florida any longer. I did in the past. I now, and we'll talk about my sort of dual professional life. I have my online telemedicine practice, which is based out of Florida. And then I do travel locums work as a cardiac surgeon. So I'm all around the country doing cardiac surgery.
Oh, that's cool. I didn't realize you were doing that, not locally. Okay. Well, yeah, why don't you tell us a little bit about who you are and what you do, since I kind of jumped the gun with a normal question. But
yeah, sure thing. So, you kind of, I guess, gave away the ending because we met at a metabolic health conference, and that really has become a major focus of my professional life. But going back before that, I've been a cardiac surgeon now over 20 years. And, I've done well over 3,000 heart surgeries during that time. And I think the relevant personal information is for most of that time, I was a very unhealthy heart surgeon. And I reached a point, this is now going back about 10 years, where I was morbidly obese. I was pre-diabetic. And I recognized that I was headed for my own operating table, so to speak. I was certainly traveling down the same path that so many of my patients had gone down. And like so many of them, I really didn't know what to do about it because I was following the advice that I was taught to give, that we all have heard: eat less, move more, eat a low-fat diet, watch your cholesterol, and kind of follow the food pyramid. And I saw how that wasn't working for me and how it wasn't working for the patients that were ending up on my operating table. So fortunately, I started getting exposed to some different information. My journey really started with my wife, who, after she had had our children, was really struggling with heartburn and had seen a number of practitioners, and someone suggested to her that she go gluten-free, she eliminate gluten from her diet. And, being at that time the sort of traditionally educated and kind of mainstream thinking cardiac surgeon that I was, I said, well, that doesn't make any sense. You don't have celiac disease. Why would you need to eliminate gluten? But I was also a supportive husband, and I said, if you want to try it, I'll try it with you. And so this is about 8 or 9 years ago at this point. And they didn't have a lot of the gluten-free, options that are certainly available today. And so we kind of went low carb unintentionally. We stopped eating bread, we stopped eating pasta. And I noticed pretty quickly that I felt better, just had more energy, even before I started losing weight. And so I kind of filed that away and said, that's interesting. And then a few months later, after kind of just doing the gluten-free thing for a little bit, I was at a conference, a Society of Thoracic Surgeons. So this is the biggest meeting of heart and chest surgeons. And there happened to be an invited guest lecturer by the name of Gary Taubes. And of course, probably much of your audience is familiar with Gary. Gary is an investigative journalist who at that time had just written the book, The Case Against Sugar. And prior to that had written Good Calories, Bad Calories, and Why We Get Fat. And I heard Gary talk and, really for the first time heard these concepts of low carb and the types of food that we eat being more important than the amount of food that we eat. And so, at that point, I kind of cut out sugar. I read Gary's books, cut out sugar, went low carb, and saw amazing results. Lost over 100 pounds and really got in the best shape of my life, felt better than I had. At this point, I was in my early 40s and felt better than I did in my 20s, got back to wearing smaller clothes than I did in high school. And that really opened my eyes. And I started asking questions like, why did I learn about this from a journalist? no offense to Gary, hadn't ever heard of this from my colleagues in medical school and training or anything. And it also led to some additional questions about heart disease in particular, the disease that I had dedicated my life to fighting against. And maybe what we had been told about the causes of that and how to manage it weren't the full story. So here I am now, 8 or so years after that. And like I said, I now have a telemedicine practice where I help people not to need heart surgery. I wrote my book called Stay Off My Operating Table about 2.5 years ago now, and are really on a mission to educate people on how they can avoid the need for heart surgery.
Yeah, amazing story. I have so many questions. Obviously, we're both kind of coming from mainstream medicine. How did they get and why did they get Gary Taubes to speak at a cardiothoracic conference? Do you have any idea?
Well, that's pretty interesting. And I've actually asked Gary, and he honestly says, I have no idea. He was kind of on his book tour, and I guess someone in the leadership of the organization must have been interested or maybe knew him somehow and thought it would be an interesting lecture. The ironic thing is, I'm at the meeting and you've been at the conferences and you know how this goes. You're going through sort of the program book and you're like, what can I maybe skip out on and go enjoy? We were in Phoenix, Arizona. I can go enjoy the weather. My family was in town with me, go hang out with them. And I'm looking at the program and I'm like, who is this journalist? What is he talking about? Like, this has nothing to do with heart surgery. So, this is maybe I can skip this one. But for whatever reason, I didn't. And obviously, I'm very glad that I did. But I still, to this day, have no idea how he got invited. And I also kind of wonder, I was in that room with 1,500 other heart surgeons or, thoracic surgeons. Like, how many of them did it have the same effect on?
That's what I was going to ask.
That as well.
So I'm assuming you have no idea. Is that true? Like, why do you think other people pulled the same information that you did and changed everything?
I mean, what I can say is I'm the only cardiac surgeon I know of really out there talking about preventative health and in the metabolic health space. The one other I guess I can point to would be Steve Gundry. He's been doing it for a very long time, has maybe a slightly different focus, but we certainly overlap on a lot of issues. So Steve would be the only other one that I would point to in the cardiac surgical world doing this. And of course, as you know from being at the Metabolic Health Conference there, even in the cardiology, the broader cardiology space when it comes to heart disease, the concept of metabolic health and insulin resistance is still very much ignored.
Yeah, absolutely. I agree. And it's sad, but I think that, the research is coming out and hopefully we'll all catch up, I think, for sure. Otherwise, I think I'm going to ask you some questions later that, what do we do with these current guidelines and recommendations that were given? And I just want to hear your opinion on that. But first, I wanted to have you unpack a little bit of what your diet looked like before and after this change. Like, what kind of things were you eating? What were you doing? And then what about afterwards?
Yeah, so before this, I certainly wasn't eating the typical, what we think of as a standard American diet full of junk food. I was raised in a household. My older brother is a type 1 diabetic. So we had no sugar in the house. We had all of the low fat, low sugar. We had margarine instead of butter. We drank skim milk on our Cheerios or our Wheaties every morning for breakfast, and it was very much, I would say, in line with the guidelines. And despite that, I battled with obesity since childhood. And, many times I would do the standard thing. I would, really get serious about counting calories or really go on the low fat diet, and I would lose some weight. And then, like most people, I would gain it back and more, because we now know that these approaches just they're not sustainable, because they're really not compatible with human nutritional needs. When you go on a very low calorie diet and you're trying to starve yourself, that just isn't going to work long term. And when you go on a low fat diet, you're not getting the essential nutrients that you need. And so we know that these approaches don't work in the long run. Yes, you can get some short-term success. And I did, I can think of 2 or 3 times in my life that I lost, 50 pounds, but gained it back within a few months. And so it was particularly powerful when I was able to lose all of that weight, but now here I am 8 years later maintaining that weight loss. And it's really easy for me to do it. I don't have to struggle in battles. After hearing Gary talk, after, like I said, I really cut out sugar, had cut out gluten, really got low carb, I guess what most people would think of as keto, and did that probably for a year or two. And then I heard a crazy orthopedic surgeon by the name of Sean Baker talking about the carnivore diet. And again, I said, well, that sounds really insane, only eating meat. Even though at that time I was exceedingly low carb, I was probably under 20 grams of carbs a day. And the reality is that I was eating a lot of meat and eggs and, animal products with a little bit of vegetables. But I said, well, let me give this a try for 30 days and see what happens. And I felt even better. The interesting thing for me was so I lost the weight. I picked up running as a activity, and I developed plantar fasciitis in my right foot. And for probably a good year or so, I just could not get rid of it. I did all the stuff. I would rest, I would stop exercising, all the physical therapy things, changing your footwear, all of that. Just couldn't get rid of this plantar fasciitis. And I went carnivore. And my third day on carnivore, I get out of bed, and for the first time in about a year, my foot didn't hurt when I, kind of put it down for the first time getting out of bed after a night of sleep, and the plantar fasciitis went away. And early on, if I would kind of stray a little bit, maybe have something with some sugar or whatever it is, I would feel it in my right foot. But, so I was able to finally get my plantar fasciitis go away. So that was another improvement. And then I've stuck with a carnivore approach since then because it's just the easiest thing for me to maintain. I really don't have to think about it. You're not counting anything. And so it works well for me. I always tell my patients, like, carnivore isn't the only approach that works, but I want people to understand it's an option. And that, of course, brings up the whole discussion around, well, isn't red meat horrible for your heart, like we've all heard our entire careers and lives? And the reality is that no, red meat is not damaging to your heart or your health. And so in some ways, carnivore is also a demonstration, I guess, of this, that, you kind of take it to the extreme of only eating red meat. And we have now this large community of people doing that. And they're overwhelmingly seeing great improvements in their health. And I can even zero in on the heart health aspects of this and say that, we are seeing great results with this.
What kind of results are you seeing? And before that, what do you think? Is it just decreased inflammation and why plantar fasciitis might have resolved with the carnivore diet?
Yeah, so I think the plantar fasciitis was related to inflammation. There was something that I was still eating. In retrospect, I can look back and say, well, at that time, I wasn't really paying attention to the vegetable and seed oil issue. I would eat the sort of keto treats that you see now, or maybe it was something from, the plant kingdom that I was still consuming in small to moderate amounts that was causing this inflammation to be persistent. And that was a demonstration of the inflammation going away. I can also point to inflammatory blood markers like C-reactive protein that we see uniformly improve when people go on, low carb carnivore type diets. So, and of course, that has relevance to heart disease. Inflammation is one of the driving factors of heart disease. Broader than inflammation, I point to insulin resistance. And Insulin resistance, we know, is a primary driver of heart disease and heart disease risk. And every study I've looked at that looks at insulin resistance as a risk factor for heart disease, it is a much larger magnitude risk factor for heart disease than LDL cholesterol elevation is. And yet somehow we just ignore that. And we've gotten the messaging, and you alluded to the guidelines. The guidelines say control cholesterol, and they do not mention insulin resistance at all. And I look at that now and say, hold on a second. We have all of this data. And again, this isn't new data. Gerald Reaven did the seminal work around insulin resistance and heart disease in the 1980s, 1990s, and clearly showed that insulin resistance is a major risk factor for heart disease. Now, that doesn't mean that, cholesterol is meaningless. It just, what I'm trying to get people to understand, and this includes my colleagues, to understand, is that insulin resistance is a much bigger risk factor. So let's pay attention to that one. And then we can have the discussion around, what is the real impact of cholesterol.
No, I think that's a really, really good point. I think that you said a couple things. You mentioned the keto treats, right? So I feel like there's those more processed foods. I don't know what's all in a keto treat, but they're still keto, but they still have some sort of processed food, I'm sure. And hopefully not those seed oils you were referring to. And then when you were back doing gluten-free, like you said, they didn't have as many products as now, but now they have all these other substitute products to be gluten-free that still are highly processed and have a bunch of junk in them that probably are not as good as, they should be. So it's going gluten-free doesn't really give you the result of what you're describing here, like anymore, I would say. Right.
Yeah, I would agree with that completely, and really my thinking around, what we should be eating has really come around to, first and foremost, we need to eat real food and whole real food. And I describe it to people as the things that grow in the ground and the things that eat the things that grow in the ground, basically plants and animals. And then, I am open to variations within that. I work with people who are kind of, on the vegan vegetarian side of things. And of course, I work with a lot of people who are on the carnivore side of things. And they both can work as long as you're eating real food. Because, one of the things I talk to my kind of vegan vegetarian leaning patients about is you can't be eating that junk food either. And there's a lot of vegan vegetarian junk food, just like there's a lot of keto junk food that you mentioned. And all of these things, the food industry finds a way to kind of, bastardize them. And honestly, that's another advantage of carnivore, is that they haven't quite figured out how to make processed carnivore food. I mean, I guess you can point to some things like beef jerky or sausages that are loaded with sugar. And so, you got to be careful on that front as well. But it hasn't quite gotten to that point yet that we see, sort of what I would call carnivore junk food. And so that's another advantage of it. All of these things that we point to, is it sugar? Is it vegetable and seed oils? What is it about the food processing? Ultimately, I find that carnivore really helps to eliminate all of those issues.
So comment on fiber intake when you're carnivore. How does that work?
The answer is that fiber is not essential to the human diet. And again, it's one of those interesting things that you look at, that we've been sold this narrative that fiber is essential for health. And really, when you look into the science behind fiber, the only thing that's been demonstrated is if fiber replaces processed food, junk food in the diet, then fiber is beneficial. But outside of that, I would say that no one's ever demonstrated that fiber in and of itself is beneficial. And we now have a large carnivore experience, both modern carnivores, people that are doing it now, but we can also go back through the literature and we see, meat-based diets being promoted going back to the 1800s and probably even many people would say it was our ancestral diet. And, people do just fine without fiber. And so I don't consider fiber to be essential. No one's ever demonstrated fiber to be essential. And so the answer is you don't need it. And I can personally say, and of course, the large carnivore experience community around me can say that they do just fine without eating any fiber.
So what I was explained at that conference actually was that if you're in ketosis, your body can create butyrate, which is what is needed to feed the gut. So you don't need the fiber to feed the gut. That's what I was kind of told. Is that?
Yeah, I mean, it's interesting. The whole concept of fiber is that, it basically is an undigestible, we as human beings cannot digest fiber. And they'll talk about digestible versus undigestible fibers. The reality is that all fiber is undigestible to humans. So, it's supposed to somehow kind of pass through your GI tract and help give bulk to your stool, which is an interesting concept. Like, why would we need that? And then, like you said, maybe, have some effects on the microbiome and kind of feeding some of the gut bacteria. But again, the gut bacteria can do just fine without it. And I think there's still a lot we don't understand about the microbiome, and we're not quite at the point yet that we can use that, I think, to truly guide our nutritional advice. And I think there's a lot of bias within the microbiome literature that they basically started with the concept of, a heavily plant-based diet was the ideal one. And so whatever that microbiome looks like, that's the ideal microbiome that we should all be pursuing. And again, we don't have the outcomes data, I would say, to really support that at this point.
Okay. So you alluded to one of the biggest misconceptions in the current healthcare system regarding heart disease, I think, with the low-fat diet. What would you say are some other ones?
Yeah, so everything that's kind of around the low-fat, so what we can call the diet heart hypothesis or the lipid hypothesis. And, again, many might be familiar with this, but the history might be new to some people. This really started in the 1950s. So, when you look back here in the US, in the early 1900s and certainly the late 1800s, heart disease is basically undescribed. It is a very rare occurrence. And we have kind of the lifetime reports of the leading physicians of the time, and they hardly ever saw cases of heart disease. And, starting in the early 1900s, we start to see this rise in heart disease in the US. And it really kind of reaches a crisis point in 1955 when our president, Eisenhower, has a heart attack while in office. And this appropriately sets off the alarm bells, and everyone's, kind of trying to figure out what's causing heart disease. And there were two prevailing theories of the time. One was basically championed by Ancel Keys. And Ancel Keys, who, is a physiologist, a researcher, is promoting the hypothesis that dietary cholesterol, and specifically dietary saturated fat, is leading to increased blood cholesterol levels. And those increased blood cholesterol levels are then leading to the plaque buildup that we see in the arteries, atherosclerosis, as we call it. And, this makes a little bit of sense because you look at these plaques and you see cholesterol in them. And so you then say, okay, well, this cholesterol has to be coming from the bloodstream. And, there was some, I would say, poorly done science at the time that correlated eating cholesterol with your blood cholesterol levels. And really, it was just conceptual. There's cholesterol in our blood, there's cholesterol in the food. So, the more cholesterol you put in from the food, it makes sense that, the more is going to end up in your blood. So that was one hypothesis. And the competing hypothesis, which was, championed by physicians like Dr. Young, was that sugar was really the primary driver of this increased incidence that we were seeing in heart disease. And I will just say that for reasons that weren't completely scientific, the cholesterol hypothesis won out. And that became the prevailing hypothesis around heart disease. Now, there have always been some problems with it. And the early scientific studies show an inconsistent relationship between the amount of cholesterol and or the amount of saturated fat that someone eats and their blood cholesterol levels, and then inconsistent relationships between blood cholesterol levels and heart disease. We can go back to some of the early data. So the Framingham study, very large, famous study that many people are familiar with. And this was really the first study that suggested that there was a relationship between blood cholesterol levels and heart disease occurrence. But interestingly, that was only shown to be the case at very high levels of cholesterol. We're talking about total cholesterol levels in the above 300 range. And what we now recognize, but they didn't fully understand back then, is that the people that had those levels of cholesterol, a lot of them have genetic issues, what we call familial hypercholesterolemia. And those genetic changes don't only affect your cholesterol levels, but they also have a lot of other effects in things like your blood clotting system. And this has influence on heart disease. So anyway, we get set down this pathway, and then it just becomes really a kind of self-feeding proposition, because it just becomes the baseline assumption that cholesterol is the problem when it comes to heart disease. And of course, that leads to the US dietary guidelines suggesting low-fat, low-cholesterol dietary approaches, with the unintended consequence of, when you take fat out of food, A, you're processing it, and B, you got to substitute something in to make the food palatable, and that becomes basically sugar and processed carbohydrates. So that's problem number one. And then, of course, the pharmaceutical company gets involved and comes along with medications to lower cholesterol, which increases our focus on this even more.
Yeah, in medical school, we learn to treat the disease with medications and everything instead of preventing them. So obviously statins are one of the big things that we learn to treat cholesterol with. So what is your, opinion, guidelines with using those?
Yeah, I look at high-level evidence. And the high-level evidence shows us that statins have been, one of the most, if not the most widely prescribed class of medications in the United States now for over 30 years. And heart disease is not changing. It's not going away. And in fact, it's getting worse despite this. And, the corresponding data is that our cholesterol levels on a population, when we look at population wide, our cholesterol levels are lower than they've been, and heart disease isn't going away. So that's, kind of red flag number one for me when it comes to statins in particular, and really the whole cholesterol-based hypothesis of heart disease. I alluded to earlier the numerous studies that we have showing that insulin resistance is a much bigger risk factor for heart disease than cholesterol is. And so, again, my focus is, let's address the insulin resistance. Clearly, the cholesterol approach in and of itself is not adequate, is not working. And then we have to acknowledge the potential harms that come from trying to lower cholesterol. And this really applies to both, the diet and lifestyle approach to lowering cholesterol, as well as the pharmaceutical-based approach to lowering cholesterol levels. Because as I've mentioned earlier, if you're going to take a dietary approach to this, and that centers around lowering the amount of fat in your diet in general and shifting the fats that you consume from saturated fats to polyunsaturated fats. And I would say that neither of those has shown to be beneficial. And really, you can point to harm. There have been, 3 large interventional trials substituting polyunsaturated fats for saturated fats. And they have all failed to show benefit, and they, point towards harm. And again, we can look at the Minnesota coronary experiment, we can look at the Sydney Diet Heart Study, and we see that the outcomes were worse in the groups that were getting the polyunsaturated fatty acids as opposed to the natural saturated fats that we've been consuming as human beings for our entire existence. So, the dietary approach ends up not being a good approach. And oh, by the way, when you lower the fat, you increase carbohydrate intake and particularly processed carbohydrate intake, and you make people more insulin resistant and more prone to things like type 2 diabetes. That increases their risk of heart disease even more. So that doesn't seem like a good approach to me. And then, on the pharmaceutical side of things, it really comes down to the benefits are disappointing. They're small magnitude at best. And the long-term effects of being on these medications are really concerning to me. When I look at data that shows, for instance, that, if you're on a statin for more than 5 years, you have a significantly increased risk of developing insulin resistance and type 2 diabetes. Again, the two primary drivers of heart disease. That's why I don't think we see the magnitude of benefit that you would expect to see if it was all about cholesterol. Because the reality is, even in the best statin studies, and understand that a lot of this science is kind of corrupted by the fact that it was done by the pharmaceutical companies. They don't, allow the data to be scrutinized by third parties, especially early on in the statin experience. They're very selective about how the studies get done and what gets published. But even if you accept at face value the best data we have around statins, in the primary prevention setting, so someone who has not yet had a heart attack or a stroke or needed a stent or bypass surgery, the absolute risk reductions that we see from taking statins over a 5 to 10 year period are on the 1 to 2%, reduction. And so again, when you look at the data that way and you say you can take these medications, for 10, 20 years, and you can reduce your chance of having a heart attack by 1 or 2%, most patients aren't too excited about doing that. And again, that's with the trade-off of you're probably increasing your risk for things like diabetes, insulin resistance, and maybe some other things as well.
Do you know mechanistically why the statins induce like diabetes?
Yeah, they're basically a mitochondrial poison is the way that they work,
Okay.
and so they interfere with metabolic efficiency and metabolic processes. And that is what leads to their, increased risk of insulin resistance and diabetes.
I see it all the time when a patient comes to me on a statin and, guess what? Now you have prediabetes or diabetes. And it's ironic because anytime we have a patient with diabetes, we're supposed to give them a statin, right? For
Yeah,
the cardiovascular
exactly.
risk reduction, which apparently
Exactly.
is 1 to 2%. So
Yeah.
that's not very helpful.
And,
Yeah. And we
and
get dinged
again,
on it if we don't.
oh yeah, no,
Yeah.
exactly. It's the way the guidelines are written. And the other concern I have is that it also is giving that message to the patient of, don't worry about what you're eating. The medication fixes it. Go on living your life and eat whatever you want. We have medication for that. And so that whole pharmaceutical based messaging, forgetting about the specific medications, again, we need to get back to diet and lifestyle being first and foremost. And in order for that to work, we need to be giving people good diet and lifestyle advice.
Mm-hmm.
And we have now, again, clearly demonstrated that, therapeutic carbohydrate restriction is the best way to deal with insulin resistance. We can reverse type 2 diabetes in the majority of cases. And again, this is published literature from things like Ovadia Health, showing this. And that should be our focus, because if we eliminate the insulin resistance, that is going to have the most powerful effect if we're trying to prevent heart disease, along with many of the other chronic diseases that we're battling against as well.
The statins definitely, give that permission to eat whatever you want as well. And that's probably also part of the downfall. Speaking of insulin resistance and that everything and improving upon that, what is your thought on the GLP-1 receptor agonists that are used for insulin resistance treatment? And how does that play a role into the cardiac health too, since now they are approved for that as well?
Yeah, so I think the data around GLP-1 agonists and cardiovascular disease is interesting. And I think we have to first of all, make some distinctions between, the ways that these medications are getting used for weight loss versus the ways that they have been used. I mean, these medications have been approved for a decade to treat diabetics. The dosage is different. We are using higher doses when we're talking about weight loss versus diabetes management. And I think that may be very important. And, again, my hesitation comes with the drug focused approach. So, but I do acknowledge that there is a role here. And if you have a patient that's insulin resistant, I think that GLP-1, and there's concern for cardiovascular disease, or they have diagnosed cardiovascular disease, there's probably a role for these GLP-1 agonists. But, again, with the patients that I'm working with, that goes along with the message of this is what we need to do to reverse your insulin resistance from a diet and lifestyle approach. And once we accomplish that, now these medications aren't going to be of any benefit for you. So, we don't want this to be a lifelong, just stay on the medication. It may be useful as an adjunct in the short term, and let's get your insulin resistance reversed with, proper diet and lifestyle approaches. And then we don't need these medications anymore.
Yeah, I agree. I think, they are supposedly meant to be used long term and forever potentially. But if you're really making those lifestyle change in habits, which it can be helpful for, especially getting the motivation in the beginning to go, because it really helps quiet that noise, then they can make those changes to go, whatever way they need to go on their lifestyle thing. So I think they do have a role, at least like for starting out as well. And then, I mean, I assume that there's cardiovascular benefit because it's the overall weight loss and reduction of insulin resistance in the first place, right? I don't really necessarily think it's some sort of direct mechanism.
Yeah, no, I agree completely that, that's where the benefits are coming from. And again, as we oftentimes make these same mistakes, I guess, because I look back at the statin data and, the statin trials and say, okay, over a 1 year, 2 year, 5 year, are really the longest trials, you see benefit. That doesn't mean that lifelong is a good idea. And especially, we are also seeing with these GLP-1 agonists, many of the problems that are coming, long term with them. And again, I admit that a lot of that is more with the high dose use that we're, for the weight loss purposes versus the treatment to diabetes. And like everything in medicine, there's no perfect answer. We're always balancing those risks and benefits. But I do have concerns about any really medication that we're saying, now you're going to be on this for the rest of your life. And especially when we're talking about, starting them earlier and earlier. So, one of the other mistakes I think we've made around statins is, there was just, okay, you demonstrate that this has some benefit over a short term in, let's say, 50 and 60-year-olds. And somehow that we're now in the situation where there are many leading cardiologists and cardiology societies that are promoting statins for teenagers because the concept has become, the earlier we start this and the lower we keep your cholesterol level throughout your life, that's the answer to preventing heart disease. And so, and GLP-1 agonists, again, the same conversations are having, the rise in childhood and, teenage obesity that we're seeing. And the answer is, well, let's start giving them all these, these medications with the intent that they're just going to stay on this medication for the rest of their life. And I think that's a very, very bad approach to be taking.
Yeah, I agree. It's a little concerning with the starting the medicine so early. I had no idea they did statins in teenagers, though.
Yeah, we're seeing it. And again, it's because we have teenagers that are being diagnosed with type 2 diabetes, which is scary in and of itself. And like you said, the guidelines say if you have diabetes, type 2 diabetes, you should be on a statin. And so kids and teenagers are getting started on these medications.
In your expert professional opinion, how do we fix this whole problem, especially like at the young age? How do we fix our food supply? How do we fix this? Any idea?
Yeah, I think it really has to be a ground up movement. This is, we can't sit back and expect that the food companies are going to change, that the pharmaceutical companies are going to change, really that the healthcare system is going to change. And so I think this starts with educating our patients. And the way I look at it is when I'm teaching my adult patient about this, that's going to translate to their children, and honestly, I see it in my children and, because they at least are thinking about this. And I'm not saying that they're perfect and they don't do a carnivore diet, but, when we go out to eat, they order steak most of the time. They order their burgers without the bun a lot of the times, and they're kind of cognizant of these issues and thinking about it. And honestly, I do see more hope in the younger generation because I think for you and I, and my parents, right, we were raised in this environment of low fat, low carb, food pyramid, and it was just kind of the dogma, and it was just accepted as this is the best approach. And now we're trying to change people's minds about that. But kids, I think, are seeing it already and realizing that this doesn't make sense. And we can get to them early with the message of, processed food is not good for us. And so I do see hope out there. There is a high school, she's just about to graduate high school as we're filming this, and she produced a documentary on cancer as a foodborne illness and talking about processed food and cancer. Her name is Grace Price. I recommend everyone go out and watch that documentary. Again, it's called Cancer, a Foodborne Illness. And so I see things like that, and I certainly get hope for the future. And I think if we get to the children early enough, before they've kind of undergone the brainwashing of low fat, low cholesterol, processed food based approach, that's where we're going to really start to have an impact on this.
I definitely think it's when the kids are more able to make those decisions, because right now I feel like they're just over flooded with abundance of everything, snacks all over the place, and they're full of added sugar and everything, and it's still there, but maybe it's just my kids' ages. I don't know, but hopefully when they're old enough, I'm teaching them that they, see these things too, because I'm trying to do that, but it is not easy when it's everywhere.
Yeah, no, I mean, it is scary, and it is a very difficult environment for us to be in. But again, going to things like the Metabolic Health Conference, seeing the increasing number of practitioners that are aware of this, because I think ultimately doctors we know doctors are getting very frustrated and getting burnt out because they're not seeing results from their patients, and the healthcare system is really failing. And so more and more of them are looking for alternatives, I guess you could say. And, things like metabolic health, which are growing, and going to these conferences, I see more and more practitioners from more and more different specialties that are becoming aware of this and are implementing it into their practices with great results. I look at something like the large focus at that conference on metabolic psychiatry. And, people like Christopher Palmer and Georgia Ede, and all the great work they're doing to show that much of the psychiatric epidemic that we are up against can be attributed to poor metabolic health as well. And so the message is starting to spread, but like I said, it's going to be very much a grassroots, bottom-up effort. I'm not expecting the American Heart Association to turn around anytime soon and say, we were wrong, but clearly they are wrong. They've been wrong. Again, I look at an organization like the American Heart Association, who, their singular focus for the past 70 years has been to battle heart disease, and they are very clearly failing in those efforts. Heart disease has done nothing but increase under their watch, under their guidelines, under their recommendations. And I think it's time that we as physicians partner with our patients to start pushing back against this.
Oh, I love it. Absolutely. I completely agree with everything. I just want to thank you so much for your time. I know I could probably keep you here asking you a million questions, but I know you're a busy guy. So how can people find you? And then tell us a little bit about I think you started the Metabolic Health for Practitioners Society, or is that right? Is that the name of it?
Yeah, so I am one of the founding members of the Society of Metabolic Health Practitioners. I think for any practitioner that's interested in metabolic health, that is where you should start. And they have certification programs, they have educational programs, and really they're giving, the practitioners what they need in terms of writing guidelines. And now there's a journal that they're publishing, and just that community support, I think, that we all need as physicians as we're trying to maybe incorporate this into our practices. So definitely a plug for the Society of Metabolic Health Practitioners. Personally, I can be found at iFix Hearts everywhere. So all the social medias at iFix Hearts, and then you can go to ifixhearts.com and find out all the ways that my team and I are working with patients. I do have a telemedicine practice. I see patients all throughout the United States to try and keep people off the operating table. That's largely my focus, and more broadly, educating people on metabolic health. And then the book is called Stay Off My Operating Table, and it is widely available on all the usual places.
And your podcast, Stay Off the Operating
Podcast
Table.
also called Stay Off My Operating Table.
And did you have a TEDx talk on the same topic? I haven't seen it yet, but
yes. I did. I was
okay.
Very honored to be actually invited back to my medical school alma mater, Jefferson, to deliver a TEDx talk. And so the talk has now been out on the TEDx YouTube channel now for about 2 months, over 300,000 views. So it's been very well received. And I get excited about the advantage we have today is social media and the internet. Yeah. So these concepts can spread. I look back on my career as a heart surgeon, and like I said, I've done, over 3,000 heart surgeries, but you're only impacting kind of one person at a time. Mm-hmm. And I look at some of these other avenues, there are large podcasts that I've been on that have 2 million views. The book has sold at this point, I think, over 50,000 copies. And I just look at the scale that we can get this information spread at. And that's what I'm passionate about.
Yeah. Well, congratulations on all your achievements, and, thank you for doing what you're doing and spreading the word. And and thank you for educating me. And I think, like you said, we need this community, and I definitely need more friends and people on this same pathway as I am just, kind of starting out on. So I appreciate that. I appreciate your time, and thank you so much for being on the podcast. And if anybody is interested in having a primary care provider that does do insurance and try to, I guess, break some of the rules, but follow them too, I'm, passionate about helping everybody's metabolic health as well. And they can come find me.